ladies and gentlemen. I am Dr. Chaturvedi, welcoming you on the behalf of Pharmaceuticals to this conclave on right vitamin D interventions, strategy for better patient outcomes. I believe we wouldn't have chosen a better day for this because today is a very auspicious day as per Indian culture and tradition. We are celebrating Guru Purnima. We bow down to all those energies for being our guiding light in different walks of life, illuminating our journey and empowering us to achieve our highest potential. Wishing all honorable faculties and esteemed audience and a blessed Guru Purnima. With these words, I am taking you further on this program where I'll be first introducing and talking about my organization, Pulse Pharmaceuticals. Then I'll introduce the faculty, and then I'll be handing over to the faculty to take us further and enlighten us. Pulse Pharmaceuticals was started 27 years ago, and we have been present across the country and in the emerging markets. We are a patient-centric, innovation-driven, integrated pharmaceutical company with an inclusive growth model. We learn, we understand from you what are the limitations of the existing medicaments, drugs, whether they are pharmacokinetics or pharmacodynamics, and then we try to improvise and innovate on them. We have world-class R&D and manufacturing infrastructure, which is spread across the country. A strong leadership team and operational teams across all business functions. We have 7 divisions. We cater to orthopedics, we cater to neuropsychiatry, we cater to obs and gynae, pediatrics, and general medicine. We lead in the space of nanopharmaceuticals and drug delivery research. One of the hallmarks of our work in pulse nutricines, and we have been following in immunocell therapeutics by developing novel CAR-T technologies. For this, we are collaborating with the Center for Cellular and Molecular Biology, which is a Hyderabad-based organization. Our business philosophy is to create customer value through high-quality differentiated products and services by using advanced and patented technologies. We have 7 patented technologies which we use in various products. And when we are talking about vitamin D, it is the actual technology which is being used. We have with us to talk to us about vitamin D and its importance, Dr. RAJNI Sharma, who is Additional Professor, Division of Pediatric Endocrinology, All India Institute of Medical Sciences, New Delhi. Dr. Sharma is a graduate and a postgraduate from All India Institute. He is a former Joint Secretary of Indian Society of Pediatric and Adolescent Endocrinology. He is a recipient of Sir Dorabji Tata Prize for Best Undergraduate in Biochemistry. He has been awarded Royal College of Pediatrics and Child Health Ashok Mathwani Visiting Fellowship in 2015 in Pediatric Endocrinology, and she has 73 index publications and 28 book chapters. I welcome you, madam, to this program. We are also joined by Dr. B.M. Makkar, who is Director of Dr. Makkar's Diabetes and Obesity Center based at New Delhi. Dr. Makkar is immediate past president of RSSDI. He has been an honorary secretary of RSSDI from 2017 to 2019. He is a member of Executive Board of Diabetes India. Dr. Makkar has been associated with various committees of American Association of Clinical Endocrinology since the year 2014. He has been recipient of various awards and orations, including RSSDI Gujarat Chapter 2019, Diacare Gold Medal Oration 2022, Professor Siddharth Shah Memorial Lecture in 2023 in Mumbai, and he has published various books and has published in various national and international journals, the peer-reviewed journals. I welcome Dr. Makkar to this August gathering. And last but not the least, I am joined by Dr. R.K. MARWAHA, Major General, who is a consultant endocrinologist and scientific advisor to International Life Science Institute, India. Dr. MARWAHA also have a certification in molecular endocrinology from Middlesex Hospital, London. He is a postgraduate certificate course in hospital administration from New Delhi. Dr. MARWAHA is a former additional director, senior consultant, and head department of endocrinology and research center at INMAS DRDO, which is based at Ministry of Defense, New Delhi. He is a recipient of Commonwealth Fellowship in the year 1985, WHO Fellowship in the year 1987, and is a past president of Indian Society of Bone and Mineral Research. He has 145 original publications in peer-reviewed international and national journals with more than 7,000 citations. With these words, I welcome Dr. Marwah. And before I hand over the session to Dr. Marwah, I'll request my colleague, Mr. Raghu, to play the corporate video, and then we will be taking over the discussion part. It is over to you, Raghu.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
Thank you, Raghu, for playing that video. Now I invite Major General Dr. Marwah to initiate the discussion. I think probably he'll briefly speak about basics of vitamin D before he takes on further the discussion. It is over to you, Dr. Marwah.
Thank you, Dr. Harsh, and thank you, Pulse Pharma, for inviting me today in the conclave. And as you all know, that vitamin D is a very important hormone, which is not only necessary for maintaining calcium balance and safeguarding skeletal integrity, but also essential for overall health and well-being. It is primarily acquired by exposure to sunlight. Food articles commonly consumed by Indians do not provide adequate vitamin D, and no food articles till recently.
So sorry to interrupt, but voice is not audible.
Am I audible now?
Yes, sir.
Okay, so the food articles commonly consumed by Indians do not provide adequate vitamin D. The most sensitive index to define what is vitamin D deficiency is to evaluate vitamin D, that is serum 25-hydroxy D levels. Nutritional rickets and vitamin D deficiency continues to exist as a major health problem in India. Just to briefly remind you of the physiology and the synthesis of vitamin D, that is synthesized in our skin by exposing the skin to ultraviolet B rays of wavelength 290 to 350 nanometers, where 7-dehydrocholesterol in the skin gets converted to pre-vitamin D, and from there it gets converted to D3. From D3 through the blood, it gets passed on to the liver, where enzyme 25-hydroxylase converts it to 25-hydroxy D3, and from there, it gets passed on to kidney, where 1-alpha-hydroxylase converts 25-hydroxy to 125, which is an active vitamin D, which brings about the action of vitamin D. There is another, this is the classical pathway that I described. But there is a non-classical pathway where several cells of other systems also have vitamin D receptors, and 125 acts through these vitamin D receptors. For instance, for immunity, macrophages and other cells, all the immune cells have vitamin D receptors where it takes care of modulating immune profile. Now, various types of vitamin Ds are available. Now, the different metabolites of vitamin D, the most common one is D3, which is known as cholecalciferol, which comes from the animal source. And this is actually, it is normally formed in the skin, as I mentioned earlier, from dihydrocholesterol by UVB rays exposure, and the half-life is about 2 to 4 weeks. The other vitamin D is ergocalciferol, which is from the vegetable source, and it is formed by exposing mushrooms, yeast, and other fungi to UVB rays. Calcidiol is 25-hydroxy-D, and another preparation is calcitriol, which is the active vitamin D, where the half-life of only 4 to 6 hours, and the requirement is daily in this case because of its short half-life. We all know that vitamin D is a very important nutrient for the whole body. It actually acts on all the systems of the body. And why I say so is because vitamin D receptors have been reported in all the systems of the body, even besides your GIT and bone mineral metabolism. So since the vitamin D receptors are present all across the body, it has extraskeletal benefits. And also we have seen that there is a correlation which has been established, especially by observational studies, that those with low vitamin D deficiency has a lot of other systemic disorders. And the other thing, why vitamin D works, another thing is that it controls at least 3% of your total genetic control is through vitamin D. So that is the reason why vitamin D acts on all the systems of the body. Now, to briefly tell you, to make things clear right in the beginning, we earlier used to have classification, what used to be called as Lipps classification, where less than 5 nanograms was considered as severe vitamin D deficiency, 5 to 10 moderate, and 10 to 20 mild. But recently, Institute of Medicine has classified vitamin D deficiency based on the serum 25-hydroxy levels of 12 as the cutoff. Those who have less than 12 nanograms per ml are considered to be vitamin D deficient. 12 to 20 are considered to be vitamin D insufficient. More than 20 is sufficiency. Whereas American Endocrine Society has defined less than 20 nanograms per ml of vitamin D deficiency, 20 to 30 as insufficiency, and more than 30 as sufficiency. This is not to confuse you, but all over the world, now it is the Institute of Medicine classification which is primarily being accepted. So less than 12 will considered as deficiency and less than 20 as insufficiency. Now, what are the causes of this vitamin D deficiency? Probably the most common cause is inadequate sun exposure, which may be due to people not spending enough time outside, or because of cultural reasons that they cover their bodies, like Muslims, and in Rajasthan, the ladies keep their bodies covered. Older adults, low dietary intake, malabsorption syndrome, severe liver diseases, kidney diseases, various drugs like anticonvulsant and antitubercular, people staying at higher latitudes, and those with darker skins are the ones who are responsible, who are likely to get vitamin D deficiency. As I mentioned earlier, sunlight is the best source. However, there are very few dietary sources of D. Those fatty fishes which are there in the cold waters, that is salmon, mackerel, herring fishes, liver, cod liver oil, eggs, and some of the foods which are fortified do provide us with vitamin D. But most foods being consumed by Indians do not contain any vitamin D. And So why is it so difficult to get our daily requirement of vitamin D? Because we do not expose ourselves to sun between 11 and 2, which is the best time to expose, because that's the time when you get maximum UVB rays on Earth. Indians have darker skin, so less formation, poor exposure, less formation, and because most of the foods still are not mandatorily fortified in our country. So these are the three important reasons why Indians have vitamin D deficiency. And this is a slide which clearly shows that more the level of vitamin D in your body, lesser would be the systemic disorders a person would face. And this is a very example of congenital ichthyosis. I'm just trying to show you that vitamin D does work in areas other than bone health. That is, this is a case of congenital ichthyosis where you see the impact of supplementing high dose of vitamin D. This is another case. These are published cases, but needed much higher dose than normal requirement. This is a case of psoriasis, how you see high dose of vitamin D improves psoriasis. So with these few words, just to give you an idea, we are going to now discuss about other aspects with the other experts. And here my first question goes to Dr. RAJNI. Dr. RAJNI, why do you think the calcium and vitamin D are so important in children?
First of all, thank you, Pulse Pharma, Dr. Chaturvedi sir, and Dr. MARWAHA sir for the invitation. Sir, childhood is characterized by growth, and as we know, the bones grow from the cartilage is part of the growth cartilage and the calcification of this area. So calcium and vitamin D are very important for the growth of the child, and any deficiency of these two could lead to bony deformities, which is known as rickets. And so apart from the growth, the peak bone mass is achieved during adolescent period when the child grows very rapidly, and up to 80% of the peak bone mass is attained by 18 years of age. So childhood is the main time and adolescence when bone is accrued in the body. So if there is any deficiency of calcium or vitamin D, then the long-term reserves are very low, and this predisposes children in later adulthood or in old age to getting osteoporosis. So that is why it's very important.
What are the adverse effects of chronic vitamin D deficiency in children that you see?
So vitamin D deficiency is very common, as sir mentioned, in our nation, in our country, due to various reasons. And what are the effects that we see of vitamin D deficiency? Number one is that it is to be remembered that a combined deficiency of vitamin D and calcium would lead to more symptoms. So the most common complaint that we often get is bony pains and muscle pains that the children have. Apart from this, then they can develop bony deformities like rickets, which usually manifests with knee deformities. That is, either the legs are bowed like genu varum in early childhood, or they can have knock knees, genu valgum in older age group. Apart from this, if severe vitamin D deficiency can also affect the growth, and of course, as I mentioned, the bone mass. In childhood, vitamin D deficiency rickets can also predispose to recurrent respiratory tract infections.
Thank you, Dr. RAJNI. Dr. Makkar, now, how do adults with chronic vitamin D deficiency present to the clinicians? And what adverse effects do you see when the adults have chronic vitamin D deficiency?
Thank you, sir. First of all, I must thank Pulse Pharma, Dr. Harsh, and of course you, sir, to involve me in this very important discussion. So, vitamin D deficiency in adults is usually not symptomatic. Most of the time, we discover it on the routine investigations done for multiple reasons, mostly for workup of the non-communicable diseases or the chronic cardiovascular risk situations. Now, some of the times people will come with vague pains, low backache, and very, very vague symptoms from where you can actually, try to correlate that, okay, this may be because of vitamin D deficiency when you see the low vitamin D levels. Especially in elderly, there can be challenges because chronic vitamin D deficiency can lead to osteoporosis and osteomalacia, and these people might present with the pathological fractures or, fractures with the very low intensity injuries. There again, this can be one of the presentations. But most of the time, adults usually don't come with any complaints related to vitamin D deficiency.
Yeah, that is very well said that most of the subjects who have vitamin D deficiency are usually asymptomatic, or they may complain with vague body aches and pains. And you have to really assess very carefully whether they do suffer from vitamin D deficiency or not. However, if there is a chronic deficiency of calcium and vitamin D, they may result in osteomalacia, osteoporosis, and fractures, pathological fractures. Rajni, you did mention about rickets in children because of vitamin D deficiency. It is very sad that this country is still, we have children suffering from rickets, which is actually been eradicated from other parts of the world. So in case you see these children with rickets, how do you treat them with, in different age groups? How do you kind of manage these children over a period of time that they completely heal their rickets?
First of all, when we get a child with bony deformities or suspected rickets, we would like to investigate and do the serum calcium, phosphorus, and alkaline phosphatase, the RFTs, as well as do X-ray of the wrists and the knees. And once the diagnosis of rickets is confirmed, then we go ahead with treatment. As we know that nutritional rickets is the most common cause, so we treat with a very high dose of vitamin D, much more than the RDA, along with calcium. So the doses which have been recommended from the Indian Academy of Pediatrics in infants less than 3 months, 2000 IU of vitamin D per day for 90 days, and 50 to 75 mg of calcium daily for 2 months. In older age group, that is up to 1 year, we can follow this treatment. But generally above 6 months, we can also give loading dose, like a higher STOS therapy of 60,000 international units once a month for 3 months with calcium, as mentioned. And for the older age group, more than 1 year, we would go ahead with the daily therapy of vitamin D, 3000 IU per day for 90 days, and calcium, 50 to 75 mg, maximum 500 mg for 2 months. So this is the treatment we follow. Generally, if the age is above 12 years, we may even go for higher doses like 4000 IU per day. And sometimes in children, we also can go ahead with STOS therapy, that is 60,000 IU fortnightly for 5 to 6 doses along with calcium.
How long do you take these treatment? To recover fully?
So this treatment of, if we give daily vitamin D, it's given for 90 days, that is almost 3 months. And calcium is given for 2 months. Generally, recovery starts happening within 1 month. So we can start seeing changes, healing of rickets after 1 to 2 months of giving vitamin D therapy. But generally, we do all these tests because earlier we were giving STOS therapy. And after completing the therapy, we were looking at the X-ray changes and healing of rickets after 1 month. But nowadays, since we are giving a prolonged therapy, we do the X-rays and the biochemistry after the end of the therapy.
Yeah, we've carried out several studies in rickets in Indian children, where earlier we used to give intramuscular injection, 1 shot of 6 lakhs or 3 lakhs. And we've seen all these children recovering fully by 12 weeks or maybe 14 to 16 weeks. Do you still recommend intramuscular versus oral? What is the latest recommendation to treat this? Because in our country, I think intramuscular injection turns out to be much cheaper way of treatment and the compliance is there. With oral, I think we do not find the compliance to be very good. So what is your advice?
So we are getting intramuscular preparations almost 6 lakh IU, but we have found that they're very toxic. It leads to very high levels of vitamin D. which can lead to vitamin D toxicity. So generally we are avoiding, and we have, as the various studies have shown, daily therapy or even STOS therapy is equally effective. So generally we do not go for intramuscular preparations unless the child has malabsorption, which is a kind of a very different situation.
So coming to Dr. Makkar, how do you manage these adults and elderly people who come to you with these chronic vitamin D deficiencies? And you could also elaborate on the various preparations of vitamin D3 that are available in the market. And what are the recommendations? Do you find any differences in different preparations or?
Thank you, sir. So usual, therapy is usual treatment that is given is the standard oral preparations. Most of the time we don't, use the intramuscular preparations, and the standard protocol is to give 60,000 units once a week for 6 weeks, and then followed by, the daily maintenance dose, which is in the range of about 600 units of vitamin D, along with the daily maintenance dose of calcium. But challenge is, despite the standard protocols being in place, there are, very variable kind of regimes being used at different levels of physicians, diabetes physicians, or endocrinologists. But generally it is, 60,000 units given weekly for 6 weeks. Some people are going up to 12 weeks also, and followed by the maintenance dose. Now, another important question is which preparation. So we have a number of oral preparations. We have chewable tablets, we have granules, we have capsules, we have, the solutions, we have nanoparticle solutions, we have mouth dispersible strips. So there are all kinds of preparations are available. And there is some data to show that the solutions do little better than the other preparations, especially the nanoparticle solutions. But over the therapeutic period, I think they all are able to achieve the therapeutic concentration that we are looking at. So irrespective of what you are using, important thing is give a proper adequate dose of vitamin D to achieve therapeutic concentration and maintain it further.
Well, there are 3 Indian studies which have very clearly shown that the nano preparations of vitamin D have definite efficacy over conventional fat-soluble vitamin D in terms of achieving higher levels of 25-hydroxy. We are not trying to say that you should only give that to achieve. Other preparations can achieve 20 nanograms, but the advantage of nano is that the absorption is much better. Here I'm going to ask Dr. Chaturvedi as to why is it that the efficacy of nano is higher than the conventional fat-soluble vitamin D.
Thank you, Dr. Marwah. That's a very interesting question. Ladies and gentlemen, I'll like to bring forth certain issues. Before I respond to that, I will also take this opportunity to address the issue of intramuscular injection, which both Dr. Sharma and Dr. Makkar also talked about. We have recently concluded a multicentric trial in 3 tertiary care teaching facilities, where we have compared our vitamin D solution, Deksel, with intramuscular injections. Now, I was surprised with the findings because, like everyone, I also thought that intramuscular injection is going to give me a much better rise and a much better level. But contrary to this belief, the findings were very different. We had much higher levels with the oral solution than with the 6 lakhs IU injection. Then I started looking at the available literature because I had to justify this finding. And I realized that when you give an intramuscular injection of 6 lakhs international units, you will typically get a rise somewhere after 2 months and before 4 months. It works very slowly because it forms a depot in the muscle and gradually releases the drug from there. In comparison, when you give the oral formulation, especially the nano formulation, you will achieve a peak level which is much higher, twice or thrice of that of intramuscular injection at that stage at the end of the first month. Now, why does this higher level? Though eventually we are talking about the levels, and why is there a need to achieve more than, let's say, 30 nanogram per ml? Now, as I understand, the level of 30 nanogram per ml being considered adequate was arrived at because it just managed to keep PTH in the check. That's about it. So if you are looking for any musculoskeletal benefit, probably a level of 30 to 35 nanogram per ml is fine. But when we are talking about extraskeletal benefits, when we are talking about, let's say, use in the patient of PCOD, where we are trying to talk about the impact on testosterone and SHBG and other things, we are talking about diabetes, we understand that somewhere you require a level of 50 to 60 nanogram per ml to achieve and have a meaningful impact. That's why you see most of the studies, because the formulations are not achieving that level, that studies come up with the negative findings. Third thing, which I have realized when we did the work during COVID on COVID-19 infection patients, we gave a high dose 6,000 IU every day for 10 days. We call it PulseTV therapy. At the same time, another institution did the study. The big difference was they stopped at 50 nanograms per ml. They did not dose further once that level was achieved. And we achieved about 81. Now, where lies the difference? The inflammatory markers, whether we talk about CRP, whether we talk about IL-6, whether we talk about LDH, whether we talk about D-dimer, whether we talk about improving N/L ratio, everything came down when you have a level of above 70 nanogram per ml. So inflammatory markers do not come down easily just because we have achieved a level of adequacy of 30. Probably it's time to revisit those levels and think in terms, because even though, as Dr. MARWAHA mentioned earlier, talking about toxicity, which hypervitaminosis, I understand, doesn't mention as anything more than hypercalcemia, basically, right? Now, probably we are looking at somewhere, at least I have seen somewhere in studies on psoriasis, in multiple sclerosis, where very high doses have been used of 30,000 international units every day for 6 months. As long as you have kept ionic calcium at 1.3, as long as you manage to keep PTH above 20, even if you have a level of 225 and 225 hydroxy, nothing is going to affect the patient. It just remains fine. Yes, you have to have dietary restrictions. Now, coming back to, sorry, I've taken too much time. Coming back to the point, the nano formulation, especially Deksel, it is not about only the size. You can make a small size formulation. It is about a delivery system. What we have done, we dissolve vitamin D in lipids, which are considered as GRAS, generally recognized as safe. Then we cut them into nanoparticles. These nanoparticles, their surfaces are coated with hydrophilic polymers, and these polymers provide protection against gastric acids. They provide protection against the lipases, and they enhance the stability in presence of, they prevent the photolytic degradation of vitamin D. You'll see that most of the vitamin D formulation, they come in the colored bottles, amber colored bottles, because it undergoes oxidative and photolytic degradation. So we enhance the stability, and therefore we circumvent any need, any physiological requirement of physiology to participate in the absorption process. It's a preformed particles, nanoparticles. They are picked up by lymphatics. They are taken up through other places, and they help us achieve a much higher level. This much greater stability, even towards the end of the shelf life, which is 2 years, and we have data up to 3 years now. And interestingly, if you have seen some work which came out from All India Institute of Medical Sciences, I think Dr. MARWAHA was involved, Dr. Kadgat was involved in that. You see the formulations against a label claim of 60,000 have 5,000 IU, or they have 99,000 IUs, because stability is the issue. Ours, we just have 20% overages in our formulation, and it works remarkably well. So the idea is something which I would like to hear from Dr. Marwah also and other faculty also. Is 30 the really level we are looking at, especially when we are looking at extraskeletal benefits? And if you are not, we need more than that. Yes, a nano formulation is far superior and will help you achieve those. Over to you, Dr. Marwah.
Yeah, thank you, Dr. Hirsch. So primarily the only advantage of nano, as we said, is better and more uniform absorption of vitamin D through the gut. And since it is water miscible vitamin D, its role comes in when you have patients with vitamin D who have malabsorption syndrome, who have liver disorders, or who have chronic pancreatitis, where the lipid or the bile cannot probably make this vitamin D soluble because it's fat soluble and there is no bile or enzymes to make it soluble. So that's the reason why the absorption is lower in these subjects. And this is where nano vitamin D can be more useful. And also, secondly, if you want to achieve higher levels for some extraskeletal benefits, well, nano helps you in achieving faster. Rajni, coming to vitamin D's role in pregnancy, what is the prevalence in India about vitamin D deficiency, in not only in India, across the world, and especially in India? And what adverse effects would you see if there is vitamin D deficiency in pregnant women?
Thank you, sir. There's a very high level of vitamin D deficiency in pregnancy. If we take a level of less than 20 nanogram per ml, that is insufficiency, almost 70 to 90% of pregnant ladies would be vitamin D deficient. And so there are studies, many studies, and there's a Cochrane review also in 2016, which took into account 22 trials covering almost 3,700 women. And it showed that treating the vitamin D deficiency, it would lead to decreased risk of preeclampsia, gestational diabetes mellitus, as well as low birth weight. Apart from this, there are some studies which show that it could reduce the incidence of rickets in the child, and it could have some benefit on the infant growth, but this is not proven otherwise. So it's very important that there are guidelines from the India also to treat vitamin D deficiency and to treat pregnant women with vitamin D and calcium from the second trimester of pregnancy onwards.
Yeah, so the most, it is always in the last trimester that the maximum vitamin D from the mother goes into the child. So at least if one has not supplemented vitamin D in the first 2 trimesters, at least make it a point to at least supplement in the 3rd trimester where the maximum vitamin D gets through the placenta to fetus. And well, there are conflicting studies. As she mentioned, Cochrane review very clearly shows the benefits, but there is a very large study from Sri Lanka which has not shown any benefits on the various parameters in terms of length, weight, and other physical parameters in newborns born to mothers with vitamin D despite supplementation. So we still are at that point where we need more studies to show the benefits of supplementing vitamin D during pregnancy. And the requirement in the pregnancy is between 2,000 to 4,000 so that the newborn has adequate vitamin D in their blood and they don't suffer from the various disorders mentioned earlier by Dr. Rajni. We've dealt with the bone health so far, but one thing that I think what I need to make it clear is the maintenance dose, which has not been discussed. So up to 1 year of age, the normal maintenance dose is 400 international units per day. From 1 to 70 years, immaterial, it is 600 IU per day. And above 70, the Institute of Medicine says you can give up to 800 units per day. And Endocrine Society, American Endocrine Society says between 1,000 to 1,500 IU per day can be given after the age of 70. Because of several reasons which have been already mentioned. So with that, we would now go to the extraskeletal effects. Dr. Kakkar, you did mention about extraskeletal effects of vitamin D, and I also did that in my initial slides. But what is the role of vitamin D in pre-diabetics, diabetics, and those who are suffering from cardiovascular disorders? Does adequate vitamin D in your blood prevent disorders like diabetes or cardiovascular diseases? Your view on that?
So, one of the important things that vitamin D does is it actually, is involved in multiple metabolic processes in different organs also. And now we know from a number of studies that it is not just involved in the bone mineral metabolism, it is involved in practically lot of almost all the different metabolic processes. Now, to what extent, it is not very clear. Even you mentioned about the, gene expression, there is some role of vitamin D. Now, there are studies practically in all aspects of, I would say the energy metabolism or glucose metabolism, which have shown that it can improve insulin resistance, it can improve beta cell dysfunction. It has been shown to improve the parameters of vascular function. It has also been shown to, improve the cardiovascular risk. But all these studies that we have actually are, very anecdotal data, and they have shown association. There is not, we don't have any study to say exactly that there is a cause and effect mechanism. Now, some of these studies have shown very good association. There are studies like Nurses Health Study, which was a pretty long-term study and showed that below a particular level of vitamin D was associated with higher showed that the chances of converting pre-diabetes to diabetes may be decreased with the vitamin D supplementation. But if we look at the prevention of diabetes, we don't have any substantial data. We recently had a study called D2D study, which was a large study, from California, where 2,400 odd subjects were given vitamin D supplementation over 4 years period, did not show any effect also. So there is, data on both sides, and I think we still need more well-designed, randomized studies to answer this. But if you look at the face value of data or whatever data, if you pool it, overall, it seems that there is benefit of supplementation, at least making sure that person is getting the daily maintenance dose of vitamin D and calcium. That would be my take.
No, I would like to differ because D2D study, which was done where daily administration of 4,000 IU was given over a period of 2.5 years, did show the reduction of progression from pre-diabetes to diabetes
Yes.
from 23% to 11%. So there was a decrease of almost 10%. And there are two other also meta-analysis done in 2020, which showed that there was a decrease in the progression of this.
Yeah.
And so we have this huge study, a trial, which at least has shown some benefit in the extraskeletal. But if you take the overall data of various major trials like Vidal trial or Vida trial or DO health study. They do not really kind of show a definite causal relationship with the vitamin D. So now, Dr. Rajni, have you come across cases of vitamin D toxicity? Because this is a question which is very commonly asked. And only thing I want to make clear is that with normal treatment or with maintenance, don't please expect any toxicity to occur. This usually occurs when very high doses of vitamin D through either intramuscular injections over a long period of duration is given. So in case you have been given long-term high dose therapy, when do you suspect vitamin D toxicity? How do these people present? And how do we manage in case you have come across?
So vitamin D toxicity, sir, is, as you mentioned, it occurs only when very high doses are given intramuscular, and it's actually quite rare. But we do often come across some children who have erroneously been given very high intramuscular doses of vitamin D daily for many days. And in that case, these children can have hypercalcemia, and due to hypercalcemia, they would have polyuria with dehydration. They can have altered sensorium, or they can be highly irritable, and it can also lead to pain abdomen and renal stones. So this is the side effect that most commonly occurs with vitamin D toxicity, which is per se quite rare. More often it is seen in other conditions like maybe sarcoidosis or other conditions, but per se due to vitamin D, only when very, very high doses, and generally the level is more than 100 nanogram per ml.
Yeah, so one is that the cause of this toxicity is primarily because of high dose of vitamin D being supplemented. But then there are other endogenous causes, as she mentioned. One of them are, all granulomatous disorders like tuberculosis, sarcoidosis. Lymphoma condition is another which can give rise to vitamin D toxicity. And then in children, there is infantile hypercalcemia, idiopathic infantile hypercalcemia, which the problem is that if the toxicity is because of D3, then that toxicity takes very long. It's a prolonged toxicity because the half-life is about 2 to 3 weeks. So it takes months for the subjects or the patients to recover from this. So what you need to do is immediately stop vitamin D supplementation, calcium supplementation, all these to be discontinued. And those who have these granulomatous disorders should not expose themselves to sun and to other UVB lamps, etc. You should immediately administer sodium saline to these patients to correct the dehydration which occurs because of anorexia, nausea, polydipsia, polyuria, and all those things. And we usually treat them with 100 microgram of hydrocortisone IV over a period of few days till we see that the serum calcium levels start coming down. This usually occurs when the levels go beyond 100 to 150 nanograms. And so I think one need not worry about toxicity unless it has been given by mistake. High doses of vitamin D have been given by mistake. Now, coming to extraskeletal benefits, now we have seen that there have been very recently between 17 and 20, there have been number of trials. Vital is one trial where the trial was done in about 25,000 subjects. Vida trial was done in about 5,000 subjects. D2 in 2,500, and DO health trial again in about 2,500. Most of these trials have really, when you take overall trial, have not showed any conclusive benefit of supplementing vitamin D. There are several reasons for that, but however, post hoc analysis of Vital trial has very clearly shown that there is some benefit in the prevention of cancers. The prevalence of cancer have gone down in those who have sufficient levels of vitamin D. There are other trials from Japan, which are huge trials, and the biggest one is, I think, it was done in about almost 30,000 subjects who were supplemented vitamin D, followed for almost about 15.5 years. And they have very clearly shown that there is a decrease in the prevalence of carcinoma of liver, carcinoma of breast, in those premenstrual females who have been put on vitamin D regularly. There is another big trial by Lappe et al., which did show reduction in the prevalence of cancer, but it did not achieve significance. The p-value was 0.06, but it almost showed that the increase is there. Now, why is it that we find negative results in most of these trials? One is that they are all young, healthy people who are already vitamin D sufficient. See, if you take all these trials, 90% have got more than 20 nanograms. So we should not expect benefit by supplementation of vitamin D in these trials. Nobody has seen that whether all of them have achieved adequate levels of vitamin D or not. So we cannot say that everybody has achieved, and despite that, they have not shown any benefit. So there are several other reasons I was trying to go through, which clearly shows that maybe when you do post hoc analysis, you find different results than when you do in intention to treat subjects. Now, the other aspect which has been proven beyond doubt is by various trials is the decrease in the prevalence of upper respiratory tract infections. And this benefit comes only when you take vitamin D daily or weekly. The benefit is not accrued by those who take monthly or intermittent vitamin D. So what the recommendation now is that you should ideally take vitamin D daily, which is also physiological, or weekly, and not monthly or 6-monthly kind of a thing. Other trial has also very clearly shown a reduction in the attacks of acute asthmatic attacks, which have also been proven, and especially in those who are normal BMI and whose vitamin D is less than 12 nanograms. So if you consider a trial where you take people only with less than 12 nanograms, maybe you will see the benefits much more than the trials which have been done with adequate vitamin D levels. The other reason for not showing good results is because these, the cancers develop after a long duration. Now, vital study has very clearly showed that if you take subjects after 4 years of supplementation, they very clearly shown in those after 4 years only, the reduction in the prevalence of cancer has come. If you consider first 3-4 years, it does not have that impact because it takes much longer for cancers to develop. So you got to have very, very long trials to really show the benefits of vitamin D in preventing all these chronic diseases. Now, autoimmune disorders, well, vitamin D's role in innate immunity and adaptive immunity have been very clearly shown. However, despite preclinical and observation studies, we, through randomized controlled trials, have not been able to show improvement or benefit of vitamin D supplementation in common autoimmune disorders, except for one disorder, that is multiple sclerosis, which these randomized trials have very clearly shown that supplementation of vitamin D does prevent multiple sclerosis in young adults and children. And There are studies in every system of the body. They say it increases the fertility, better implantation of ovum. In the nervous system, they say people who are sufficient have less neurological problems. Autism is shown to be much less in those who are vitamin D sufficient. So all those things kind of are still not have taken a definite answer to the question of vitamin D helping in those areas because of the conflicting reports. So I think summarizing today's talk, what I would say is that vitamin D is important for your general well-being. Your daily requirement is, as I mentioned, 600 IU units till the age of 70, 400 till the age of 1 year. It is important to supplement during pregnancy because we know that it has adverse effects on the mother and the fetus. And the extraskeletal system needs much higher dose, between 30 and 50 nanograms to have extraskeletal benefits. But if you want to achieve skeletal benefits, 20 nanogram is good enough to achieve those benefits. And some of the drugs that you need to be careful, as I mentioned, anticonvulsant and anti-tubercular drugs, which increase the metabolism of vitamin D and decreases the levels. Obesity is one where you will always find low levels of 25-hydroxy. The caution that I want to tell you is that there are a number of preparations in the market which provide you with active vitamin D, that is calcitriol, which is not to be given in cases of nutritional vitamin D deficiency, because it has got the chances of getting into hypercalcemia is much more. So even if you have to give active vitamin D, that is 125, you need to be very, very careful to assess for calcium, hypercalcemia and hypercalciuria. But there are very specific indications only for active vitamin D, that is in kidney disorders, in vitamin D dependent rickets, and in hypoparathyroidism, etc. But for routine vitamin D deficiency, you are not to give active vitamin D, that is calcitriol 125-hydroxy D. I think with the few words, I will hand over the mic to Dr. Harsh to conclude the session.
Dr. Marwa, one thing, ladies and gentlemen, which come to me, and I would like our faculty to address that. Is it time to revisit the dose? Is it time to revisit the level, the target level? Because as I mentioned earlier, and as subsequently was spoken by Dr. Marwa, for any skeletal benefit, 30, 35 is fine. And probably that is the level which has been arrived at by just keeping PTH in check. That's about it, and nothing more than that. Now, I have read it very extensively. For any neuroendocrine benefit, as I've mentioned earlier, it is the 60 nanogram which you are looking at. And when we are talking about autoimmune conditions, which are basically inflammatory conditions, right? A level of much higher than that is required. In fact, just to tell the faculty, recently I was interacting with doctors at the railway hospital at Hyderabad, and they are working on psoriasis. And the results and the findings have been astounding, because they have been using something as a much higher dose, 6,000 IU per day, kind of a dose over a longer period of time. And as I mentioned, they're keeping a check on ionic calcium. They're keeping a check on PTH. They're not letting it fall below 20. They're not letting ionic calcium go beyond 1.3. And the results have been remarkable. Remarkable. I don't say it's a cure, but yes. Now, encouraged by them, we have also started working on a similar trial. We are also working on CKD, and which is very rightly mentioned by Dr. Marwa, that calcitriol probably is not always the right thing. and especially you cannot address deficiency using calcitriol. Now, having said these things, I would like to have a quick comment from the faculty. That is it time to revisit the dose and revisit the levels? Is it time to have indication-specific levels, indication-specific doses? Because so many of the trials where the formulations have been used, they gave conflicting results. Probably we are not
So you're right that for the skeletal benefits, maybe 20 to 30 nanogram per ml are adequate levels. But for the extraskeletal benefits that we've all discussed, levels more than 30 nanogram per ml are required. And there have been a lot of studies, especially I would say not non-clinical studies, experimental studies in which they have shown that giving vitamin D supplementation improves the adaptive immunity as well as the innate immunity, and it helps in increasing the T regulatory T cells, or various inflammatory markers come down. And from anecdotal evidence also, we know that it does help. And many studies that you're mentioning, like psoriasis, and sir mentioned ichthyosis. So various conditions, benefit is being seen. But whether the recommendations, I guess we need some more randomized control trial and definite evidence before it comes into clinical practice.
I think I would agree with Dr. Rajni, and same is the case for the, cardiometabolic conditions or vascular health or diabetes. As Sir just mentioned, that for the extra skeletal benefits, possibly the levels you require is 30 to 50. There are some of these studies which have shown benefits in people with diabetes in the range of 80 to 85. Otherwise you don't see those benefits even at the level of 50. But the question is, are we sure that this is the right level? Or maybe going to 100 will not give us additional benefits? Or what will be the optimum benefits with which dose? Or suppose we are using different formulations, which dose will achieve what level? These are multiple questions which that vitamin D has an important role to play in modifying insulin resistance, beta cell dysfunction, vascular health, vascular inflammation, and so on. And even there are studies showing very positive association with the optimum or the higher levels of. But the exact dose, achieving what levels, all these things are to be answered first, I think.
This topic is very controversial, actually. So we have done high-dose therapy for congenital ichthyosis, shown wonderful results, actually, and it's now all accepted all over the world. We gave 60,000 every day for 10 days to very small infants to cure this, not to really cure, but to have symptomatic relief and clinical benefits, followed by maintenance dose. There is a paper where high doses for psoriasis have very clearly shown benefit, and these high doses range between 30 to 60,000 of vitamin D every day for months together. But the only caution is that you don't give calcium during that high dose, and you don't allow them to take dairy products during those days, and keep a very regular check on your serum calcium levels and PTH levels. If the PTH levels don't go below 20, take it from me, there is going to be no adverse effects, because there is primarily the action of that high vitamin D is on the local skin cells. It doesn't act on the vitamin D acting on the kidney to produce 125. 125 hydroxy is produced in the local cells itself, which has an action to improve all the keratotic lesions of the skin, which has been very clearly seen. And and it is not in all cases of psoriasis that you see this. It's only about 30% psoriasis, which shows the results to be very gratifying. And so I think all these studies need large randomized controlled trials, which are on way actually. And we are trying to work out how we can do these large trials with higher dose of vitamin D levels. But this is not for the discussion for a normal nutritional vitamin D deficiency, but only for extraskeletal benefits, that also in limited number of conditions. But only thing I would say is that long-term trials are required even to show the benefits in terms of prevention. Now, recently, I think there was a report from Japan that all those with colorectal cancer who had sufficient vitamin D levels had decreased prevalence of colorectal cancer. And the reason being they detected P53 protein levels to be low, because P53 gene is responsible actually for multiplication and proliferation of the cells. So those who had sufficient levels of vitamin D, they prevented this gene P53 from being mutated and prevent cancers. And now that's how we kind of suggested that this particular gene should be looked into all the other cancers, whether vitamin D does prevent mutation of this particular gene. Having said that, we recently published two important works with the role of high dose of vitamin D in improving the efficacy of COVID vaccine. And we have very clearly shown the benefits of, we gave active vitamin D 25 hydroxy. And we clearly showed the gene pathway for improving the T2 memory cells for this infection, as well as also in the first paper, we did show decrease in the inflammatory cytokines and improvement of IL-10 and other reasons, and the remission or relapses of this infection was much less in the group who were supplemented with vitamin D than those who were not. So they were more prone to developing or reoccurring of this COVID vaccine. So I think we are at the nascent stage of knowing what its extraskeletal benefits are, and a lot of work needs to be done.
Thank you so much, sir. One last question which comes to me. It deals with the aspect of vitamin D resistance. Now, since you have mentioned genetics, so obviously this question comes. So first is how frequent, how common it is in your experience. That's number one. Number two, how do we overcome it? One of the ways, obviously, is increasing the dose, which we have been doing with even antibiotics when we see the resistance, getting the MICs right and increasing the doses. That is one thing. Second thing is, do we add something further on to vitamin D to overcome this challenge? Because I understand it's a reality, right? And many a times the responses may not be coming what we are looking for because of this particular reason. I would like to have a quick comment from all of you on this aspect, starting with Dr. Marwah.
Very difficult question to answer. When I say resistance, it's a very rare phenomenon. Resistance has to be either at the vitamin D receptor level, or it is post-receptor level, or there would be not adequate receptors to respond to vitamin D levels. So cause could be any. So we have to do genetic studies. And that's why nowadays they say that you have to have Mendelian randomized trials, which means in genetics, you take a population, evaluate 25-hydroxy. You will have about, say, 5 to 10% of people who are genetically having low vitamin D levels. And it is the gold standard now that you do Mendelian randomized trials. And that's how multiple sclerosis benefit was shown only in the randomized trials and not conventional randomized trials. So if some people are genetically, because the receptor defectors have been known, so the 3 common vitamin D receptors that we see in GIT have been shown to have resistance, but that's a very, very rare situation. So I really don't know. And I think most of the extraskeletal benefits which come is primarily because they have resistance to vitamin D, whether in terms of receptor or post-receptor defect. That's why high dose of vitamin D, giving them high dose, they respond only to high dose and not to low dose. This is a conjecture. I'm just trying to kind of analyze scientifically why it could be, but I truly have no answer for that.
I don't think I can give you anything better than what Dr. Marwah just said.
I agree with sir. In pediatrics, we see it very rarely. It's a genetic, it's inherited type 2 vitamin D dependent rickets. So, but sir is talking about something different, which is a very, which has to be looked into.
Yeah.
Thank you so much for enlightening us on this. And ladies and gentlemen, one last word. I have had a few interactions over a period of time, and especially when I was thinking when Dr. Makkar made a mention of osteoporosis, especially today, we are looking at a situation when we are talking about denosumabs being used. We are talking about injectable drugs, abandromic acid, rather than the oral ones. And these are the times which warrant a rapid and a quick rise in the level of vitamin D. Today, for this quick rise, even when you look at the kidney guidelines and other things, nobody is recommending intramuscular injections because we know they are very slow, they take a whole lot of time, and somehow, surprisingly, paradoxically, I would think that all the time hypervitaminosis is being documented. It is because of the AM injections and never because of the oral treatments. So probably it's time to revisit the levels. Probably as somewhere I thought of a thing that Dr. Marwah emphasized, we are in the realm of more of a personalized therapy at the moment, using what our experiences are, which formulations, and targeting those levels, which is important. Having said that, I go back to our earlier belief when I was a child. My parents told, and they used to mention that Indians cannot have deficiency of vitamin D. And believe me, almost data shows somewhere from 50 to, can we have a little bit less AC, please? So somewhere between 50 to 95%, 96% of the population, whether we are Fitzpatrick type 5, 6, it is because of that, whether our nutrition or whatever it is. But yes, we are deficient. And our lifestyles, sunscreens and clothes, they all make things very difficult. So it is imperative to use vitamin D. It is imperative to supplement vitamin D and to maintain adequate levels of vitamin D. It may, somewhere it surely helps, and somewhere it may help us in preventing many treatable, curable diseases and a whole lot of problems. With these words, I thank our faculty members, Dr. RAJNI Sharma, Dr. Makkar, and Dr. Marwah for a very enlightening discussion that we have had today. Thank you very much, audience, for participating in this. And it is over to you, OrthoTV. Thank you so much.
Thank you. Thank you, everyone.